Hey, everybody. Hope you're doing great. It's me, your coach, Jacob, for English at the Ready. We're here with Dr. Nathan today, a doctor of pharmacy, who's going to answer your questions in our Your Questions Answered series. Dr. Nathan, how are you doing today?
Good. Thanks, Jake. Thanks for having me on and let me answer some questions and see if I can get anything figured out for anyone. Um,
Fantastic. We're so happy to have you. So Dr. Nathan has been a pharmacist for how long now?
so actual pharmacist since 2020, so 4 years.
So 4 years of pharmacy experience, plus how many years before that studying to become a pharmacist?
Yeah, so my pharmacy experience actually goes back a total of 18 years. I was a technician, pharmacy supervisor for a hospital, then ultimately decided to go on and complete my PharmD. So quite a bit of time spent in the pharmacy world.
So we call that an investment, right? An
Yes.
investment of time. So we talked about financial vocabulary last week in our weekly classes. And again, investment doesn't always mean money. Sometimes it means time. It's what's a word, Nathan, for things like time, for things that aren't money that you put into getting a greater return.
Um, so first thing
It's
is it's not always tangible.
not
So
always tangible. You can't always touch it.
yeah, so normally I'm thinking like time, energy, relationships. Sometimes they have to take a little bit of a backseat.
There you go. And what do we call those? They're things that you can spend that aren't money. They still have value.
I'm thinking variables.
Variables. If you're a business, you have your financial money, these, and then you have your other physical, the
Oh,
starts
um,
with an A.
assets.
Assets.
Uh,
There we go. Yeah,
yeah.
yeah. Assets. There we are. Keyword. I talked about how important this word is. Just period. Assets is a really, really useful word in finance and in just about any other walk of life. Your assets are what you bring to the table. They're things that add value to you that you can spend to increase your abilities or increase your output, depending on what we're looking at. Good. All right. Nathan's quiz is over. Anything else you want to tell us about yourself? Just give us a
Um,
quick rundown on who you are and what you think we need to know about you.
Yeah. So I know one thing that's really big in healthcare is being able to travel and have experiences across different areas of the United States, and it could even be internationally. But mine is local as far as the United States goes. I started off, I was born, raised North Carolina, and then I moved to Knoxville, Tennessee. I've lived in Texas, down in College Station, and from there back to North Carolina and ultimately to the University of Tennessee, where I spent 12 years in Knoxville. And then my wife and I, we've moved to South Dakota. I did my second year of residency, which we'll get into, in Rapid City, South Dakota. And they offered a job and we've stayed. And so we've been around the United States for a little while.
Yeah, great. See, it's a long path. We're not talking about just a couple of years. We're talking what, almost 2 decades of work
Yeah.
has gotten
Yeah.
you to this point. Um, how do you like South Dakota? What are your thoughts about South Dakota? It's not a place people, when they think of the US, they think, oh, New York City, LA, Orlando, Florida, Disney World.
Yeah, no, it draws a lot of attention. They're like, "Why did you leave?" Because a lot of people in South Dakota want to go back east,
Sure.
and I'm like, "No, I came out west." We're actually considered the Midwest, almost into the western states
Mhm.
of Montana, Wyoming. But if you like the outdoors, national parks, I'm within a day's drive of 7 national parks. There's all kinds of outdoors. If you're a hunting, fishing type individual, great area.
Mhm.
We're the pheasant capital of the world. So if you're into pheasant hunting,
I didn't know
yep,
that. The pheasant
yep,
capital of the world.
uh, yep. They imported, let's see, pheasants imported into South Dakota in the early to mid 1800s from China. And oh, yep. And they've become a part of the economy essentially. I mean, a large
Pheasant.
amount of money.
Describe a pheasant real quick.
Yeah.
What is a pheasant?
It is a ground bird mainly. It does fly, but for short distance. It's kind of like a chicken almost. It's kind of like a pretty chicken.
I like
Uh,
that description. A pretty chicken, a pheasant.
yeah. The male pheasants, they are very colorful. They have a blue kind of teal on the wing. They do have longer tail feathers that are kind of like a turkey or a um, tiger striping kind of. So they're real pretty. Um, but yeah, so they're probably around the 4 to 5 pound mark in size. They do have some spurs, like a rooster would.
Those spurs are
Uh,
on the back of the heel, right?
correct.
Like you
Yep.
think about the dinosaur Velociraptor. This is
Oh yeah.
adaptation, to use another word that we used weeks ago in our biology lessons, an adaptation that it has for protection.
Yes. Yep. So yeah, it's a huge part of the South Dakota economy now, as far as the hunting goes. Yeah. Without it, a lot of small towns in South Dakota would probably go under and not be functional. It's dependent very much so in the central to north central towns in South Dakota.
See that again, I learned something anytime I interview someone for these. For these, your questions answered. I have to get used to saying that in sequence. Your questions, I call them the YQAs a lot. Your
Oh,
questions answered. So for the, you may hear me say this in the future, YQAs. Um, I'm learning things too from people who are interviewing with us. It's super, super interesting stuff. Again, pheasants. Some of you also in our classes have known that I've talked about driving on the opposite hand, on the left-hand side of the road in the UK. The only time that I almost had a wreck from doing that was when a pheasant, yeah, because pheasants are in the UK as well. When a pheasant ran across the road, it scared the crap out of me. Just this bird, what is that? It's this big, pretty chicken, as you called it. It's this
yeah.
big, pretty chicken running across the road. All right, let's get into our questions here. So all of these questions come from our students. I may have adapted a few just to make them not better, but to make them shorter or to make them more concise and just the way they're displayed. But what to expect, just like our interview with Dr. Jessica, the veterinarian, same structure. We'll ask a series of personal questions about Dr. Nathan and his practice, and then some general pharmacy questions, more about just pharmaceuticals and the study of pharmacy here in the United States. And I think a few questions are somewhat internationally related. And then we have the lesson related questions, which are questions that are more or less related to the lessons we taught on biology and some of the questions you've asked in our medical science sections that we've had before. All right, Dr. Nathan, personal questions. How did you decide to become a pharmacist?
So that's actually a really good question. And that goes way back. Even when I was little, I was in kindergarten and we did this thing where we could, and it's back in the day where you could still walk down the street for a long ways in a small rural town. We walked from the elementary school, maybe half-mile to the local pharmacy. It had the typical bar where they served ice cream. They made sandwiches. It was also his daughter was a pediatrician and she worked on the upstairs half. But I still remember to this day walking there. He let me actually come back behind the counter and start mixing creams for him and stirring them up. So that was really neat. That stuck with me. And then I progressed into high school. I started working as a pharmacy technician at CVS, which is a local retail chain. Worked there all through college, and started as I was in college, starting to more, I guess, study the biologies, the chemistries, the analytical chemistries, and it just drove that inspiration and that dedication a little further. And then life happened, went down the road, ended up trying to study wildlife and fisheries, and did a master's at Texas A&M for wildlife and fisheries. Didn't really care for it, difficulty getting a job. Entered back into hospital technician role, where I was promoted to pharmacy supervisor and managed technicians, managed pharmacists. And then from there, really liked what I saw. I got to work closely with some of the pharmacists, wanted to take more of that role on. so my wife, she finished veterinarian school, and it just came to the point of, hey, what do you want to do? And I was looking at pharmacy school, med school, and vet school myself, veterinarian school. And it ultimately came down to I really love pharmacy, so I went and applied, and here I am. And it turned into a year of residency, and then I wanted to pursue a little more education and specialize. So I specialized in oncology, or HEMONC, which is hematology oncology pharmacy.
And that's
Um,
HEMOCK or OC,
yes,
OC.
yeah, HEM/ONC, HEMONC.
Ah, there we go. Now say it
Yeah,
again. HEM/ONC.
ONC.
Would
Yes.
you spell it with all caps like that? HEMONC,
Yes, perfect.
just like that.
Yep.
Okay. Just sometimes we do use all caps for things like this, and sometimes we don't, because all caps typically indicates that it's an acronym, where this is more of a shortening, hematology/oncology. But in this case, it is still all capital, as you can see on the notepad here. HEMONC. Thank you.
Yes. So yeah, so that's what brought me to be a pharmacist, and I've been doing it now for 2 years, or well, 3 years as a oncology pharmacist, and 4 years total as a pharmacist, and love it. So
And love it.
yeah,
Simple as that. Love every day of it.
yep. It gets stressful. Any healthcare, well, I take that back. Any job has its stressors. Healthcare is not exempt from that, and they carry their own set of stressors. So you have stress, but you're helping individuals.
What are some of those specific stressors that you've come
Hmm.
across in your just your career in healthcare? I worked once, and most of the students do know I worked in surgical services at Wake Forest Baptist University's Medical Center, and I can make some guesses as to what you might say. They're outliers. They're different than they are from, say, you have human services, which are, food service is a human service, but that's not the same as a hospital healthcare oriented human service. So what are some differences or some things that are
Yeah.
specific to that?
Yeah. So specifically for pharmacists, I would say some of our biggest stressors are repayment from insurance. So PBMs, primary beneficiary manager.
I say that one
Uh,
more time. PBM.
yep, PBM. And they control a lot of repayment. So the physician comes in, sees the patient, and says, you have this type of malignancy, you need this treatment. So we go back, we look at the guidelines, determine if it meets guidelines, and then if it does, it's approved, and then it goes to our authorization team, and they approve it. Well, send it to the insurance, and then they approve it or not. So there's a little bit of what can be considered or seen as, I guess, dictation of practice, which is frustrating for not only physicians, but pharmacy, nurses, the patient. So we have to deal with that. We have to make cases and arguments as to why the specific treatment needs to be had.
Mhm.
And then, so that's one of stressors, repayment. The next one is formulary. So a lot of it comes back from the hospital. Okay, there's 2 or 3 different medication options, but one may be more expensive. They do the same thing, accomplish the same goal, same mechanisms, but one may be newer than the others and cost more. So we have to design and come up with a formulary for the hospital, and specifically for our clinic, what will be allowed. So making sure that conforms. Let's see what else. Oh, education of patients. It is stressful to make sure you have all different levels of understanding. In healthcare is like, I almost like to say, it's almost got its own language. It's almost a foreign language, where there's so much vocabulary.
I say this all the time too.
Yeah.
Again, our not medical students, as in future doctors, but pharmacy students, nursing students. We have quite a few of them, and people who are doctors, pharmacists, and nurses already. When you're learning the English for these terms, they are big words. They're very challenging. Remember, Americans, British people, native English speakers. We have to learn all of this terminology like it's new vocabulary and a new language ourselves. We spend a lot of time in undergrad just memorizing vocabulary to know what in the world we're talking about, right?
Yep, exactly. That's practically the whole first year of pharmacy school. In our let's see, what was that class called? Um, it's like Introduction to Pharmacology. It was basically 2 semesters, or it might have been 1 semester, but anyway, it was a whole class dedicated to just learning brand generic naming.
I was going to ask you that also. What do we call the naming or the nomenclature? Again, let me write that word here too. I've said this word in a class or video lesson before, but the nomenclature, the naming of things in the specialty of pharmacy is called pharmacology, right? Pharmacology
Yes.
is what you would term it. Good.
Yes.
Yeah, thank you for that. All right, let's go on to number two, not to spend all of our time on number one. Could you describe a typical day in the clinic, hospital, or retail setting as a pharmacist? And I believe you've had experience in all three of these places. Is that correct?
That's correct. Yes. So I've actually spent majority of the time in the retail setting as a technician.
Mhm.
But I did get to see it from the pharmacist standpoint very closely because I was interested in going to pharmacy school. So they spent a little more extra time. Let me see their duties.
Mhm.
Um, the hospital setting. So I actually still work in hospital. I cover our hospitalized oncology patients. And I would say that's probably 20% of my day now is hospitalized, and 80% is working in clinic, which is still attached to the hospital, but it's technically considered a clinic setting. Um,
Just how
so,
hospitalized. That's a
yeah.
word I don't believe we've used in classes yet, but it'll be good to
Okay.
see.
Yeah. So I'll kind of talk mostly to the clinic setting um, because retail has changed a lot in the probably last 15 years. Their duties have really changed. They have new metrics that their job performance is measured on. I'm not sure of those. So that's changed quite a bit. I can speak really closely to clinic and hospital. So the clinic setting, our pharmacists are divided. We have what's considered infusion pharmacists. They work actually in the pharmacy within the clinic, and they essentially evaluate the order for the clinical appropriateness. So they're looking at labs and they're looking at weights. They're looking at any side effects or recent admissions that may have been missed, any upcoming surgeries that may be impacted by therapy. And they do an initial evaluation, say, okay, it's good. It passes to a second pharmacist. They do the same evaluation. So essentially a double check. And then it gets prepared by our technicians. So that's one component of the pharmacy job in the clinic. The other part of that is actually being based in the pod. It's like POD. And it's like a little cubicle area where the physicians, the nurse practitioners or mid-levels practice. There's nurses, medical assistants, and then myself. We all sit together so that way, if there's anything that comes up, so a physician sees a patient, we're doing the initial evaluation alongside the physician, saying, okay, labs look okay. What kind we look at imaging, so CT scans, MRIs, and try to determine, okay, what kind of cancer or malignancy are we dealing with? What do I expect the physician to treat with? And then based on that go to look at their vital organ function, so liver, kidney, pulmonary in some instances, and evaluate those criteria to say catch it up front and say, okay, look, you want to use X treatment. Well, their renal function or kidney function is poor. We need to dose adjust so that way we can get that on the front end to prevent it from getting all the way to the patient or all the way up to the floor where it could lead to a potential error. So that's kind of the two jobs inside of the clinic. The hospital component that I'm responsible for We look at our hospitalized patients. So if a patient presents to the emergency department, for example, we get a little alert that says, hey, this patient has an active treatment plan, and we need you to, or basically what I'm doing is evaluating why they are there, because sometimes chemotherapy can lead to adverse side effects and put a patient in the hospital. So nausea, vomiting, bleeding, or hemorrhaging, I should say. So we have to look at why that patient is coming to the ED. We sometimes have patients that are, let's say it's a chemotherapy regimen that has a high likelihood of nausea and vomiting. They may be on home antiemetics, which are home nausea medicines, for 5 to 7 days following chemotherapy. If they get treated, then the next day, so day 2, they present to the hospital. We have to make sure that those medications are resumed appropriately so they do not develop uncontrolled nausea in the hospital. We also look at things like antibiotics. Oncology patients have specific guidelines for febrile neutropenia, so a low white blood count. If a patient presents with a
You may have to
fever,
spell that word out real quick. Febrile, right? Febrile.
yes, B as in boy. Yep.
Yep. And say the second word again. Febrile
Neutropenia.
neutropenia. Neutropenia.
Correct. Yep.
All right. It's been a while since I've had my old science and biology courses, but every once in a while I can spell some things. Again, why can I spell these words still? Prefixes, suffixes, and root words. This is what we're doing for our video lessons for this module for the next 2 weeks. And again, that's why these are so useful, is I can make a very educated guess as to how to spell these if maybe I've never seen them written out before.
Yeah, and that's a good point. That's huge. When we're reading some of the reports and imaging reports, for example, you'll see, you may not know the full word, but you can get the root word and kind of narrow it down to exactly what's being said. So even now, I still see root words. I pull it out and I'm like, okay, that's what that's talking about, or that's what that means. So it's very important.
This goes back to saying that, remember that even as native speakers, we don't know every word. We don't know every, even in our sciences, we don't know every term that we come across. But if we know root words, prefixes, and suffixes, we can make a good guess in the context in which we read it to understand what that word actually means. And sometimes with medical words, often you can directly pull out the root, the prefix, the suffix, because they're Latinate or they're Greek in nature already. So you might be able to just directly translate it to something easier to say or an easier concept to think about.
Yeah, exactly. We look at the antibiotics. We look at anticoagulation. Having a malignancy can, depending on the malignancy, can increase risk of a blood clot. So we anticoagulate, we do scoring systems, we educate the patient on anti-nausea medications. So there's quite a bit. There's a lot of patient involvement and communication and direct interaction. The retail setting, just briefly, a large portion of the day is patients will bring, or well, they don't necessarily bring prescriptions anymore. Everything's transmitted electronically. So the physician's office will shoot a prescription over or send a prescription over to the pharmacy. Pharmacy technicians will fill it, set it aside, and the pharmacist will do an evaluation to make sure it is the correct medication being put in the bottle, making sure the prescription has the correct information and required information. Some retail pharmacies do have a direct connect, so they can actually see your EHR, electronic health record. And so they're able to evaluate renal function, your kidneys, your liver, anything that may be pertinent to a particular medication, allergies, for example. And then as far as other metrics, I know they are like CVS, for example, they monitor how many vaccinations a pharmacist gives. So that's part of a metric. So they have to give so many vaccines every day. They have to make so many phone call follow-ups for drug utilization reports, which are DURs. So there's quite a bit. So it's not necessarily that it's less clinical. It's still clinical. It's more of a production environment, I guess I would say.
Yeah, this is kind of where you start applying some lean manufacturing concepts when it comes to
Yeah.
the retail side of pharmacy, it sounds like.
Yeah.
So it's
And
kind of
we still do that in the hospital. We do quality control. We do a lot of lean management style stuff
there we go.
um, to
Okay.
make sure we're saving the health system money. I mean, we don't want flagrant just waste. Um, but we do keep an eye on it.
Yeah, and again, I'll put lean management on our vocabulary list too here, because that's a good term for pretty much all business. It's you have lean manufacturing and then lean management. Lean, what does lean mean? Just simply in this context, what does lean mean?
Basically streamline, making something streamlined.
Another way to think about this is we'll talk about the lean part of an animal when we talk about meat,
Oh,
right? It's the lean part without a lot of fat. It's the main muscle that you're going to eat without the fat. It's lean.
yep.
Just a little comparison that makes it easy to understand. When you see lean, okay, it's talking about the fat has been trimmed away. There's not a lot of extra stuff there in the way. We get just what we want or just what's important for production. Good.
Yep.
Let's go on to question 3. Dr. Nathan, how did you prepare? Now, this is a very specific question, and this is asked by one of our students who actually wants to study pharmacology. What's the word? Pharmacology, oncology, oncological
Um,
pharmacy. What's the correct term?
so it's it's hard to say. Several
There are
places use
two, right?
different terminations.
Okay.
Pharmacology is the basically the study of pharmacologic oncology agents. So oncology pharmacology.
Let's go with oncology pharmacology, right?
Yeah.
Because I've heard a few different names or words for this, and I'm really not sure which one is the best to use, but
And
oncology,
oncology pharmacology, you could also hear or see oncologic
oncologic.
pharmacology. Yep.
Okay,
So
that's interesting.
that's
That
kind of
also,
goes back and forth like potato.
and oncologic would make it, when we add an IC at the end, oncologic makes it an adjective. It means it describes that type of pharmacy. So oncology pharmacology or oncologic pharmacology. It's a mouthful when you start getting into word
Yeah.
roots, prefixes, suffixes. All right, question 3. How did you prepare for your experiential work, your IPPEs, APPE as a student? And is there anything you wish you had done differently?
So yeah, this is a hard one. So I hate to say it, but there's really no great way to prepare. And this is why. So you spend, at least for me, so I went to the University of Tennessee. My PharmD was 4 years. And I also did the dual enrollment for a master's in the healthcare information and informatics.
Mhm.
So I was there 4 years. The first 2 years were essentially, well, the first year and a half were all books. So everything I was learning was in classroom, very little in the hospital, rotation type stuff. It wasn't until year 2.5 and on that I got into the hospital. So you're essentially going from applying what you learned in class into a real world setting. And in real human medicine, there is a lot of gray area. So in the classroom, you may learn, let's see, I'm trying to think of a good example. Blood pressure, for example, hypertension, so high blood pressure. You would say, okay, a person has a cough. We would not want to use an ACE inhibitor, lisinopril. That's great in the book, and that you need to know that. But in the real world setting, there could be other reasons for a cough. And so you have to take that clinical picture into your equation when you're making a decision. So there's a lot of gray area, and it's very hard for students to hear everything in a classroom And then when they come into the actual practice setting, they're doing like the complete opposite. And so it's very hard to understand the balance that you have to have. And so that's why I say it's difficult. Yeah.
Experience is what lets you make those decisions more accurately or more comfortably. And say in the
Yes.
beginning, would you say that having a level of discomfort in the beginning is normal and to be expected?
Oh yeah, absolutely. I remember, so our let's see, like year 3, 4. So 3 is where I really got into full rotation. So 4, 5, 6 week rotation. The first few, I was stressed. I was high anxiety. I was like, what am I doing? Why am I doing this? Um, but then you get more comfort. And so you start understanding patients. You understand, okay, you develop a workflow, and everyone's workflow is different. I have a particular way that I evaluate a patient and what order. My counterparts that work with me, they do it complete opposite way. They have a little bit different manner in which they look at the patients. Neither one is wrong. It is just what works well for my brain. And that's really the point of those rotations, is to get you in the process and the comfort of developing your own process of evaluation.
In your rotations or in your residency, you're attending, did you have an attending? Would that be the correct word for pharmacy?
So we didn't really have what's like in the doctor world, in the physician world, you would have an attending. Ours were called like preceptors.
Okay. I've heard this
Yeah.
word. I think you
Yeah.
mentioned this in our pre-interview. You might have mentioned this word to me, but preceptors. So
Yeah.
kind of the same as the medical school attending physicians in your situation.
Yes.
How rigid were they? And when it came to doing things a certain way, was there were some of them more rigid than others? Were most of them understanding in the way that you're saying that everyone has a different workflow?
It was hit or miss.
Mhm.
So some individuals were very structured. They wanted it done their way. I would say the better ones said, okay, this is the end goal, get it done. And you were allowed the freedom to figure out how to get to the end goal. And that's very much how I practice now. That I actually precept students. And that's very much how I practice. I say, this is what we need to know. I do not care how you get the information or what process you go through. Um, just get it done. And so they come back, we have a discussion. Now, if while we're working up a patient together, if I see, hey, they may have missed something, it may have been a little more, I guess, the long way around to get the information, I'll give them hints and tips and things to look for that can expedite their evaluation. So it's kind of letting them be in charge of their own education and then kind of step in and guide when needed. Um, but I did have preceptors that were like, I want it done this way. I want you to look at renal function first. I want you to look at liver function second. And that's not that to me, that's not a good way to learn. It's very hard.
Good. And this kind of sounds like something I say when we talk about English teaching a lot, is there's not just one way to do it. You have to find your workflow, you have to find your comfort level, and then go with what you know. And I often, maybe not, I don't know if I'd apply this with Definity in the medical environment when it comes to patient care, but when it comes to speaking English, I often say, like Nike says, take Nike's slogan, just do it, right? Just do it. It's better to do something than to do nothing. Maybe do it educatedly or in an
Yeah.
educatedly, do it in an educated way if you're in a medical setting. Would you agree?
Oh yeah, absolutely. We do have instances where that happens. Some individuals may come in with a little bit of different pathology that may not be in the guidelines, and so between the doctor or the physician and myself, we have to sit down and talk and say, okay, well, it's this pathology. We use these agents in a different type of cancer, but similar pathology. Um, what do you think about this? And then we have to educated decisions on what dosing, kind of what we're looking at. So there is some of that happens almost on a daily basis, honestly.
Good. So that's the reality of
Yeah.
practice, is again, lots of gray areas. It's not just one size fits all. It's not a cookbook. We're not baking a cake. We're dealing with the
Yeah.
human body that's a lot more variable than say baking a cake properly.
Yeah. And you know, that's the big thing with pharmacy is um, it's a joke that goes around in the field that, oh, you're just a educated lexicon, which is our reference. And so yes, you do spend a lot of time learning the basic stuff and the common stuff, but no physician is going to come up to you and ask you a general interaction. It's going to be something complicated that no one's seen.
Mhm.
And but you have to know how to go get that information, how to clinically evaluate and make a recommendation. um, I rarely have an a question of from a physician saying, "Oh, can this patient take this medication together?" That rarely happens.
Mhm.
It's more along the lines of, "Okay, this is really bad. We have no idea what's going on. Do you have any idea?" That's typically what
Little
I deal
sharing of
with.
information and getting some different ideas.
Yes, it's
Uh,
very collaborative and great. Collaborative practice, I
ah,
guess, is what you'll say.
that's a good word from this week's vocabulary, actually, collaborative.
Oh,
So fantastic. Um, that's good. That's a good, thank you for that very well thought out response to number three. I know number three is one of the more difficult questions in this interview. Also the student who asked, she knew it was going to be a difficult question. So I think you covered it very well. Thank you for that.
sure.
Let's go with four. What do you wish someone had told you before residency? And what steps should I take to improve my chances of matching for residency?
Okay. So yeah, so great question. We have this question quite a bit as preceptors of students looking to go on to residency. The biggest thing that I feel like that no one told me was how much time it was going to be.
Mm.
Everyone in school, they were like, "Oh, once you get to residency, it'll be easier than school."
Uh-huh.
That was false. Residency's harder. It's basically work and school. And then I was told the same thing going into a second year of residency. Oh, it's your second year. You have a good foundation. It'll be easy.
See,
Negative. It was even harder. So be prepared for um, the time commitment, and be very structured. Keep a calendar. Um, and I would suggest, like, I love my Microsoft Outlook. I color coded events, kept everything, and I think the biggest thing with pharmacy type individuals, we joke about that we're type A, very OCD type individuals. We like things to be done in a certain time. We want to score 100% on every assignment, um, but you have to wrap your mind around that
that's
there's
our
not enough time for a do what?
that's our student exactly. Again,
Oh,
this week we were talking about a little bit about personality types, and I can't at this moment remember the exact question we asked, but she said, I'm type A and I want to make 100s on everything. And we were talking about being a good sport. And my question to her was, well, would you screw someone over so that you could make a better grade? Like if they ask you for the notes, would you give them the wrong notes or something incorrect? No, 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 not like that. But she likes to make 100. She likes to make A's on everything. And if she doesn't, she needs to know why.
yeah,
So it's
yeah,
just, it's funny to me you say that because again, I've also told her in the past that it's a personality type often that makes a really good pharmacist. My personality type, I really wouldn't make a good pharmacist. I could probably be a pharmacist if I wanted to be, right? But that's aptitude and ability versus having the right attitude to make it the right fit.
yeah. And that's actually a good point. Kind of going off a little tangent here, but
Please.
in pharmacy school, they gave us a personality test. Well, my book is at the office actually. It came with a personality test. I think it was like 200 questions, and there were personality types that kind of directed you to what field of pharmacy, and they could kind of gauge where you needed to be. So it was interesting to see. So like, for example, if you happen to take, anyone happens to take it, I split between ISTJ and
So it's
INTJ.
Myers-Briggs.
Yeah, Myers-Briggs. Yep,
Yeah, I was
exactly.
going to ask you that in a moment, but that's
Yeah.
definitely been
And I think the name of the book was Core Strengths, I believe, but it's a very good book.
core
Um,
strengths, you think?
I think, and I can email that to you so you can get it out to your students if you'd
Please
like.
do. I'll just jot it down right here that we think right now, we think it's core strengths in quotations. Quotations, of course, you don't need. I'm just trying to separate this from the other terms that we've come across. But Core Strengths is the name, we think, of that book.
So yeah, very good book. So along those lines, once you get to residency, at least any residency program I know of does not grade you. They evaluate you. So there's no numeric scaling. It's just, okay, how are you performing? And are you getting the right clinical judgment and things into your toolbox? So essentially, you have to be okay with things not being 100%. So I would be asked randomly, say, okay, we need this PowerPoint presentation, 10 slides made to present in 3 hours. And the first time it happened, I was like, I can't do this. But as my second year of residency, especially now, I'll regularly be told, okay, we need this presented or this done, and I'll throw some slides together. I'll stand up there, I'll talk, and then I'll just go right back. Before, it was very hard, especially as going into my first year of residency. I would spend so much time striving to have everything reach that level of perfection that I had in my mind. So I think that's probably the biggest thing advice I could give somebody.
I think that's excellent advice. And also knowing the student from what they've said in past classes, I think that's going to be advice well received.
Good.
So,
Good.
and see, I understand that completely too. You talk about the classes that we develop each week. You talk about these interviews, right? I mean, this is pretty well structured, but I would love for it to be even more structured with beautiful slides and lots of designs. But the truth is, you just don't have time, and the content and the output is much more important than the way something looks or the way it's designed. Again, we want to talk about some silliness. On my other screen over here, this is just the beginnings of a LinkedIn post showing off my daughter in a breakfast I made for her one day, right? This is going to talk about the job skills needed as a father, basically. And anyway, so this has been sitting here for 2 days. I could just write this and post that photo, it would be fine. But because I'm me and I am a little bit A-type when it comes to designs, I want to make this highly personalized and make it look really good, right? So it's kind of the same thing. You have to know what you can get done in a certain amount of time and focus on what's important, and then not always let that importance be overtaken by the ideals.
Yeah.
Yeah, that's good advice.
So improving chances. So the second part of that, kind of four big things. Yes, grades are there. You have to have there's a cutoff. Most residency programs have a cutoff for GPA. So if you do not meet a specific GPA, it's kind of out of the loop, I guess. So there is a minimum. Like you do have to have a minimum. But to say that a 4.0 student is better than a 3.5 student, and most of the residency programs I recall, I think they're around the 3.2, 3.5 mark for GPA. So not your straight A students. You do not have to have straight A's.
Good advice.
But
I think nowadays, especially when you think about undergraduate in the United States, most people are scoring between 4s and 5s, and that's still absolutely insane to me. But 3.2, 3.5, that's very reasonable.
Yeah.
In the academic standards department, that's very, very reasonable.
Yeah. So kind of along the lines that will set you off, or set you apart from your peers, would be if you have any work experience. They want to see that you can integrate into a team, that you've participated in teams. So that can be work experience, that can be volunteer type of experience. So something that shows that you work in a team, work with other individuals. Projects. So if you've worked on any projects in school, that didactic, clinical type, it could be clinical, but data extrapolation, data interpretation, all of that's great to see. And I will say the biggest thing that will help someone in residency interviews is interviewing. are individuals who, and that's usually a make it or break it.
Practice doing it.
Yeah,
Interview
it's
practice.
speak in front of as many individuals as you can to make yourself uncomfortable, to get out of that peer group. If you practice in the same front of people in the same group of people, it takes a little bit off of it, or away from it. If you can really put yourself in place, even virtual, that helps a lot. Just learning to speak virtually to people can make a big difference.
I know an English club that does that completely.
Yeah,
English at the ready. Just a little plug there for anybody who's
yeah,
watching this who might not be part of the club. This is the philosophy behind this entire English club is virtually works very well for getting yourselves over the hump when it comes to your fears speaking. This is true for speaking English and for giving presentations to people, joining different groups, finding different conversation partners. Again, this sounds like an advertisement now. And you guys know me, it sort of is an advertisement, but it needs to be said that the virtual environment makes it so easy to get in front of people you've never met before and break down some of the barriers to your speaking. And again, that's with English, and that's with language learning, and that's with any other type of presentation you might give.
yeah, exactly. And a little pro tip, I will say, if you're looking at a particular residency program, you have an interview, I would look up the history of the preceptors, know a little bit about who your preceptors will be, specifically the program director, the residency program director. Look up them, see where they came from, and in the actual interview, ask them questions like, for example, I would say when I was doing mine, I would say, well, Dr. Whatever, I see, or I saw that you had attended the University of whatever for your residency program. What did you take away from that program and how did you implement that here? And so it gives them a little thought. Okay, he's looked into us. He knows kind of what we're about.
Again, do your research. This is
Yes,
general interviewing tip, like number 1, 2, or 3. It's in the top 3 probably.
yes.
Know who you're interviewing with, do your research.
Yeah, and it adds a little bit of personality to it. So it was always well received. And every time I pulled like a question like that out, it was not viewed as creepy or stalking. It was always well received that the individual did their due diligence. So yeah, that's kind of what I would say to improve your chances.
Yeah, excellent advice. And our last question for the personal questions, then we'll get away from the personal things and focus a little more on practice. What was the worst experience you've had in your career? This could take on different forms, but what was the worst experience?
Okay. That probably occurred in my first year of residency. I had a rotation, for the lack of no one knowing who I'm talking about. I will just say I had a rotation. The individual did not run the rotation very well. I had pharmacy residency interviews part of the month. It was February, a short month already. I was gone for 2 weeks for interviews, which was approved, and which made my rotation only 2 weeks long. It was not a required; it was a elective rotation. But at the end of the 2 weeks, I was told that I would not be successful as a oncology pharmacist, and that I did not have the mental aptitude to proceed. And yeah, so there was a lot of negative feedback. But I tell you that because part of residency education is knowing how to accept critical feedback, not taking it personally.
Let's highlight that, asterisk that. Say that one more time for the people in the back. This is
Yeah.
something we say a lot when we want someone to repeat something. Say it again for the people in the back. What?
Yeah. Make sure that you can understand and accept critical feedback and do not take it personally.
Excellent advice for anything.
Yes. That will carry you not only in your career, your personal life, even if someone is speaking with emotion, especially patients. I will say with patients, especially dealing with oncology patients, emotions can run high sometimes. And so you have to take a step back in your mind, evaluate, okay, what is this individual really upset about, and try to understand. So, criticism comes at us 24/7, especially in the American society. I'm not sure so much about internationally,
I've been
but
saying that lately too. I've been saying the exact same thing. And I've lived in Argentina and China, and it's something I always say about the US society is we are very competitive compared to some of the others that I've lived in.
yeah. And so I think if you can get a handle on that component, it will make just life in general easier, but it's also your career easier. I take things very non-personal. Yeah, I mean, if you tell me, um, Nathan, I don't like the way your hair looks, I don't care.
Don't
It's
care.
like, good, good for you.
Okay, it's yeah, my response is okay sometimes.
Yeah,
I had a Chinese guy do this to me once, and this is what comes out of me when someone says something I don't like. I just go thumbs up, okay.
yeah.
And it seems to
So
work because they look at you like, hey, people are just critical because they can be. And again,
yeah,
we're in a very competitive society here in the US. We can break this down, and that's outside of the scope of this interview. This is not a lesson about that. Maybe one day in the future I'll talk about it, or even talk to Nathan about it again. Who knows? But it's something when you're in the US, expect it and get used to it, accept it. And what's your advice again when you hear something that you don't like?
just say okay, or just say
Okay.
that's fine. Um,
Just accept it.
you just accept it. There's
Take the punch and
yeah,
roll with it, we'll say. Take the
yeah.
punch, take it and roll with it.
And I will say that individual, that was a very rare situation in
Mm,
all of my years,
absolutely.
in almost 20 years of practice. She's been the only individual that has done that.
That is done the same
Um,
way.
so it is not a commonality. I would not say
Our
that it's something
expectations
you
are
need to be.
still good. It's not a
Yes,
commonality. It's something that was an outlier in your experience.
yes, yeah, very much so.
Good example. So hopefully some answers to these questions for those of you who are seeking to study pharmacy. Hopefully these answer the questions you've had and help you to get a clear idea of how you can be prepared and how you can perform at your best level throughout pharmacy school. And of course, for myself and Dr. Nathan, tell me if I'm wrong about this. Good luck to all of you who are looking to enter the field of pharmacy.
Yes, we
Yes.
welcome you. We welcome you.
Well, what is it we say about what is the word I'm looking for? The doormat, the mat is rolled out. What is the idiom? Because it is on the tip of my tongue,
Uh,
just not coming.
I cannot remember.
It's not roll out the red carpet, but you know what I'm saying, right? There's something.
Laid out the welcome mat.
Let's say that the welcome
Yeah, I
mat
think.
is laid for you. We've laid
Yeah,
out the welcome mat for
yeah.
you. That's the one we're going with. All right, so we'll change gears now a little bit to general pharmacy questions. This is more about practice and things in the science and the social aspect of pharmacology or pharmacy. Question one, are the active ingredients in generics always identical to the original? Are the effects of the generics exactly the same?
Okay. So
Complicated, but
yes. So especially in my field, with oncology, we not only have generics, we have what's called biosimilars. So
biosimilars.
biosimilar. So it's basically is thought of in the general population as a generic, but it's technically not a generic, and I'll explain why. So I'm a big history person. I like to understand why we do things or why we are where we are.
Mhm.
So this generic thing kind of has a little history. So it goes back to really the 1906, so early 1900s.
Mhm.
Uh, my man, Teddy Roosevelt. I love Teddy Roosevelt. But
My
in
man, he said, my man. This is a
yeah,
guy, when you really like somebody, this person you think like them, Teddy Roosevelt, my man.
yeah, that's right. So yeah, so he had what was called the Meat Inspection Act and Pure Food and Drug Act. It was essentially the Wiley Act. So what that did, it created a Bureau of Chemistry and a Bureau of Animal Industry. The Bureau of Chemistry became what is now the FDA, and the Bureau of Animal Industry became the U.S. Department of Ag. Okay. So the in
And
19
USDA, correct? U.S. Department
yes,
of
yes,
Agriculture. So we
yep,
have the FDA and the USDA.
yep. So that's what that did. The Wiley Act created those two departments. And then in 1938 or 37 or 38, anyway, there was an elixir made. It was elixir sulfonylamide. Sulfonylamide. It essentially killed 100, 200 people across 15 states in the U.S.
Hmm.
It essentially resulted in the Federal Food, Drug, and Cosmetic Act. So that's where we get a lot of our regulations for drugs.
Mhm.
And then in 1984, year I was born, so that act is 40 years old. It's called the Hatch-Waxman Act.
Waxman.
Yep.
Would you
Yep.
hyphenate that?
Yeah, you do. Yep.
Hatch
Yep.
Waxman. Let's see if I have this right. Take a look at the screen if you would. Hatch Waxman.
Yep. Perfect.
Okay.
So that was created in 1984, and that specifically looked at generics. And what that did is it increased innovation and increased affordability. Okay. So prior to this act, 19% of drugs had a generic, and it was due to the patents. It's the patent system.
Patent system.
Yeah. And then after the act, today, nearly 90% of all drugs in the US dispensed are generic. So very few brands are now still generic dispensed. So by the act increasing innovation, what it did was essentially gives a time limited patent for development. So essentially, if you develop a drug, you have roughly 7 to 9 years patent. So it's protected. The drug company gets all revenue, essentially. They can make their money.
Essentially, just very quickly, legal term, a patent is what gives you the right of ownership of an idea or of a product. Correct?
Yes, correct.
Okay, I'm going to give you, that's a simple definition. We could go a little more in depth, but I think just a few words there is enough.
Yes. So essentially, the company that is developing the drug spends a lot of money to develop, to research, to market the agent. So rightfully so, they should be able to recoup those monies or those dollars plus some profit. Now we can get into how much profit, that's debatable, but the big thing is that they're compensated for their ingenuity. And so they give them 7 to 9 years dependent. And then what happens is, because that's already been researched and developed, a new company at the end of that patent life can then make a generic drug, which is essentially the same active molecule, but different excipients. And so the active component's the same. What we call excipients are basically fillers inside the drug that have no active component. They're just there to make it dissolve or absorb appropriately.
And these include things like the binding agents. And we talked about this in class too. These are all parts of the drug that don't have an active effect, like he just said, but they're extra and perform some function in the formation of the medicine you're taking.
Yeah. So the second drug company at the end of that patent life can essentially say, okay, I know the active component does this because all the research has been done, so they do not have to invest in the research. So they market a generic at a cheaper cost. So that helped a lot of individuals mid 80s all the way to today, to where generic drugs are more cost effective and less hard on the wallet. So that's kind of the history. The FDA, the big things they look for in a generic are the identity of the agent, the strength of the agent, the purity, and the quality of the agent. So they really make sure that the generic agent meets all of those compared to its parent compound. So that being said, I mentioned biosimilars. Biosimilars are similar to a generic, but what differs is a biosimilar is a large, complex molecule, and it's derived from a living cell line. So there's a lot of development that goes into that. And essentially, let's see, there's a handful now. I think there's 5 total. But one that we use here in chemotherapy or in oncology is bevacizumab, for example. Bevacizumab started out, it was a brand name. They came out with a biosimilar, I think it was 9 or so years later. Biosimilar agent, again, different cell line. It is still expensive. So if you think about a biosimilar being made versus a generic drug being made, it's essentially 100 to 1 fold increase in dollars. So if it cost $1 million to make a generic, it would cost $100 million to make the biosimilar.
Wow. And let's
Yeah.
just differentiate it a little more. Biosimilars, again, we have the prefix bio, which means life. Biosimilars, these are similar to the natural compounds in your body, correct?
Yes.
Biosimilar versus your generic or your pharmaceutical. Would I be correct saying pharmaceutical is a laboratory manufactured compound?
Yeah. Yeah.
In general, that's good
Yeah.
enough. And a
Yeah.
biosimilar is, again, it's lab created, but it's created from cells, so it mimics or is very similar or close to a natural compound found within the body.
Yes, that is
Right.
correct.
Good
So
differentiation.
yes.
I think that's
So
well, for me too, for me to make that connection, but I think for everyone watching, that should help to make more sense of
yeah.
biosimilars versus pharmaceuticals.
Yeah. And in order to generic and biosimilar alike, both agents, when they're being created, must meet guidelines that they do the same thing as the parent compound. So they have to show that. And the FDA does a really good job at providing that information. For generic drugs, they have what's called the purple book. No, the orange book. I'm sorry, the orange book on the
Orange book,
FDA.
like the
Yeah.
color orange.
Yep.
Orange
Yep.
book. Okay.
On the FDA website, if you type in the orange book FDA on Google, it'll come up.
Okay. Orange book, FDA, Google, if you want to take a look at this.
Yeah, it's kind of neat. Read the index because it's keyed out. It has a key, and you have to follow it to what all the letters mean. But it shows you the parent compound and then the all of the approved generic compounds and how they relate, and what's approved to be interchangeable. For biosimilars, they have the purple book, and it does the exact same thing.
All right. That's why the purple book came out.
Yeah.
Purple book. So if we type in the purple book, FDA, that shows us the information on biosimilars.
Yeah.
And the orange book shows us the information on pharmaceuticals.
Yes.
Okay, good.
Yep.
And here are those two on the notepad here. And these will make it into a reference sheet that I'll prepare after we, hopefully I'll have this done before we post the video, but it may be a day or two after we post the video. I just need to find the time to do it. But I'll go through all the words on this list and I'll give definitions along with them to help you to follow along with this interview the next time you watch it. We do have some students who watch these interviews 2 or 3 times.
Oh, wow.
Which is fantastic. Hope there's a lot of information we're covering. Some of it is more technical and some of it is much easier to understand. So watching a few times, please do. Please do.
So
Do
I
you feel like you
think
covered? Yeah, go ahead. So you
I was
think?
gonna say, does that kind of answer? I think that answers
I
number
think
one.
so. I would say
Okay.
if you feel comfortable with it, I think you've done a great job of answering number one. It's a very big question, and there are different ways you can come at this question,
Yeah.
but I feel like
Oh,
you did a
and I
good
will
job.
say with generics, not only does the molecule and the purity and all of that matter, they also make sure that it is the same dose form and route. So if it's an
Dose
oral
forms.
tablet, it has the generic has to be an oral tablet.
Okay. So the
Yeah.
same dose form and route, as you
Yes.
say.
Yeah.
Good. Let's go on to two. Is pharmacy a mixture of medicine and chemistry, or is it a science in its own right? What do you think about this question? I thought it was
So that's a
interesting.
good question. And actually part of the reason why I went into pharmacy and to get my PharmD is really is dependent on what setting you want to work in. The PharmD, very much like a veterinarian degree, allows you to work in many situations or many different types of environments. So just getting a PharmD, I could work in a laboratory making drugs. I could teach in a college classroom. I can work at the hospital like I do in a clinical situation. I can work as a drug rep and a drug company marketing. Um, so there are numerous avenues inside of the field of pharmacy. So the PharmD degree really allows you to change what you do. So if you're an individual that likes change every 5 or 7 years, a PharmD may be a good program. Yeah. So really, I would say it is a combination. Like what I do on a day to day is it's a combination of both, honestly, because not only am I looking at the clinical picture, but there's a lot of times that I have to dive into the pharmacokinetics and the pharmacodynamics and look at, okay, how long is this drug hanging around? We look at let's say an individual has a sulfa allergy. Well, it's a particular molecule that a lot of people have an allergy to or I'm sorry, I should say reaction to.
Reaction to.
Yeah. Um, and it's a specific moiety. And we can look at agents to see if that new agent contains any sort of sulfa moiety that may cause a reaction. So day to day, I use both in my line of work, but you can deviate how far you want to go into each one, dependent on your role.
Okay, so overall, you would say it is a mixture of medicine and chemistry
I
overall.
would, yeah, I would.
Okay, good. Yeah, excellent. Again, we can get more complicated with our definitions here, but in general, saying it's a mixture of medicine and chemistry gets Dr. Nathan's stamp of approval.
I do.
Say
Yeah,
it.
I need
Okay.
a little stamp. I need a little stamp that'll
You
sit
do.
up
And I
here.
wish I had something keyed up where I had a little stamp appear here.
Yeah,
Just like in classes, I need a little gold star. We're all adults, but we still laugh when we get a gold star for doing something
yeah.
well, you know? Question three, are pharmaceutical drugs a blessing or a curse? This is a more general and kind of a social question. What are your thoughts about this?
Yeah. So it's both, to be honest. It depends on how and why they're being used. Um, if you think about chemotherapy agents, for example, they are only designed to kill living cells. Okay. So we're essentially saying, hey, we're going to give you something. It's going to take you possibly near death, and then you're going to come back. So it's very hard to say, okay, well, how far do we take this? It becomes an ethical conversation, but cytotoxic agents, not only, well, some of them, the more that we get into oncology development of drugs, we're actually becoming more targeted in our therapies, so hitting specific cells. But if you look at the original drugs, which are called cytotoxics, they essentially kill every and all cell in the body. It does not matter. So it's a blessing because we may save some lives doing it, but it's also a curse because it's going to cause or likely to cause significant side effects that may increase your or decrease your quality of life.
That's a very interesting response to this one. So in a way, it just depends on your perspective, you would
Yeah.
say. They're a blessing and a curse because they are things that can, if they're not, what's the word I want to say or use, they are not mitigated in some way or another, they can cause extreme or life-threatening damage to the body. So they need to be counterbalanced in some way, or in the way they're administered, or in the dosage that they're given.
Yes. Yeah.
No, that's good. I thought this was a very interesting question when I read it. It's a short question. I think it's our shortest one, but it's one that really depends on your perspective on what you're doing when you take a pharmaceutical.
Yeah.
And
And
that
I
for
think,
me, go ahead, please.
oh no,
I
I
was
was
going to say
just,
just quickly as an anecdote, for me, this is something I realized in when I lived in Hong Kong for a little while. One of the first places I visited in Hong Kong was the Hong Kong University Medical Science Museum.
oh,
Fascinating place. And back in the early 1900s, plague ran through Hong Kong. And in Hong Kong was where the bubonic plague was figured out. That's how they figured out the vector for the plague. Well,
oh,
it was in the early 1900s during that plague outbreak that they figured it out. And you had people who lived up, you had British people. So you had essentially, we'll say white people, because that's what we had living in the upper levels of the peak area of Hong Kong. And all of the Chinese lived in the downhill portions, so the lower portions of the hill that is Hong Kong, or the mountain that is, or that makes up a large portion of Hong Kong Island. And people could visually see, okay, the people up on the hill, the white people are okay. They're safe. They're not getting sick. Why is that? And are they somehow making the people in the lower areas sick? So when the authorities would come by to investigate different homes, they would, the locals, the people living there, would prop up their deceased loved ones like they're playing cards. They make them look like they're still alive, like they're still. And I, living there, I can imagine this happening culturally. It's just a clash of cultures and a clash of medical science, because you have Chinese medicine that's been around for a long time, and they would grind up different parts of animals. They would grind up different herbs and such to administer basically pharmaceuticals in their own right.
yeah.
And some people were terrified that these white people who weren't getting sick were taking, because their loved ones would disappear. They would take them away while they're sick to a hospital, and they would never see them again. So they were afraid that they were grinding up their bones and making a medicine that would keep the white people on the peak, the British people, healthy. And this was just, again, just a mismatch of cultures. It was a huge misunderstanding of culture. So they would view pharmaceuticals and treatments coming from up the hill, so to say, as a curse on their society in the lower levels. So again, just the fascinating juxtaposition of approaches to pharmaceuticals and to medicine. It kind of hints at or kind of alludes to similarly to what you're saying now in regards to these.
Yeah, and that's actually what I was going to comment on. Is a lot of the blessing versus curse comes down to cultural aspect, comes down to the human component of use. I mean, so that, yeah, exactly.
Yeah, good. Okay, so we're thinking in the same way on that one. Good. Number 4, can you provide advice for upcoming student pharmacists on how to study for pharmacy school and pass their NAPLEX exam? I guess this could have gone on the last slide, but this seemed to fit more in the general pharmacy section for me.
Yeah. So Naplex is the big stressor. When you're graduating, you typically graduate, and I think UT had us take our Naplex 3 weeks after graduation. So you spend a large portion of your fourth year. We did what was called RX prep. I would suggest that if you are able to look that program up, and I've felt and divide it out evenly over however long you want. So ours for us was actually forced over 12 months. So we did certain number of modules over 12 months to finish the book. But it did a very good job. It went through all the big items. They have videos. There's a book that you can have that shows the written word as well as the videos. practice exams. That did very, very good job. So I would say that's probably the biggest thing. Start early, study a little bit every day, and until you get ready to take it. But I would also say that this goes back to the type A personality and understanding you need to be okay with not 100%. You will not memorize that whole book. I think it is the one I had, I believe, was like 980 some pages. So you're not going to memorize it. It's a large volume of material. I would say that one of the things to focus on, at least when I took my Naplex, was that formulas were not provided. You had to memorize the formulas. So I memorized like 2 full pages of formulas, and then when I got to the exam, wrote them all down so I could get it out of my head, so I could think. And then aside from the memorization of the formulas, I really felt like school and my rotations did a great job preparing me. I really, aside from doing RX prep as directed by my school and memorizing the formula sheet, I really didn't do any additional study. And I did well on the Naplex. But I feel like school provided you paid attention, you went to your lectures, you should be confident in your abilities. They're very generic questions. There's not going to be very detailed questions.
There's not really a lot of outside or supplemental study needed. What you've learned in school, if you've paid attention, if you've taken notes and performed well in school, you should, by all rights, perform well in the NAPLEX. Or
Yeah,
you said NAPLEX, I believe.
Naplex. That's how we say it in the South.
That's
The
how I
land
should
of
say it too. NAPLEX, I don't know why I say it that way. It's just the
hey,
way
it's
it
the
came out.
I say it like Dale Earnhardt and after a bottle of whiskey. So that's how we
The
say it in the
NAPLEX.
South. Yeah.
That in the South, we'd say, how would we say this from our region of the world? Say the Appalachian area.
Oh,
And
Appalachia.
how would we say it in Appalachia?
Oh, Naplex.
Naplex. Yeah, we'd say Plex, Naplex. Get that Naplex exam.
Yeah, I had to turn it off for the interview. So
Yeah, well, I have to turn it off every time I teach. And I told them also before that when my kids hear that Southern Appalachian dialect come out of me, they know that they better run because I ain't happy. Right.
Yep.
And I'm sure we were the same way with our parents too. If we hear
Oh yeah.
that, Jacob, oh God, oh well, okay, mama, mama, what is it? I'll respond to her, not mom, not mother, mama, what I
Yep.
do? I'm 41 years old, born in 1983.
Yeah.
I would still, mama, what can I do for you?
Yeah. Um,
Good.
Along those same lines of the Naplex, my advice, even now, is to focus your study more on the law exam. So,
On the law
pharmacists,
exam.
yeah, so we have a national license, the Naplex. It licenses us to work anywhere in the United States. Additionally, we have to pass a law exam for each state. I think there are 2 states, Idaho and maybe New Mexico, that do not require a law exam. So I took a law exam I'm licensed in Tennessee and South Dakota. So I had to do a law exam for both states. So I would say, and most people would probably agree, that the law exam is more difficult than the Naplex.
Naplex.
Yeah. Yeah. We regularly have incoming residents who come from out of state, probably at least one a year or one every other year, that don't pass the law exam the first time. They have to go and retake it. For whatever reason, individuals think they just put it to the back burner. It's not a priority. I want to study for the Naplex. I would say, in my opinion, reverse it, focus on the law, and just kind of do background studying with the Naplex. But
That's excellent advice. Again, since counter logic there would
yeah,
be that you would study for the other sections, but the law section again is the one. Don't overlook it.
yeah,
It's important
exactly.
and probably what you would need the most refreshing or the most focus on.
Yeah, exactly.
That's excellent advice. These are the things that someone who's been through it like you would know from your direct experience, and someone who just teaches the test or talks about the test, or if I were just to research it on Google, I might not see that bit of advice.
Yeah, yeah.
Good. All right, one more time, we'll change to third gear here and talk about lesson related questions. So this section, these are things that have to do with questions we've either asked, been asked in class, or they relate in some way to previous lessons here at English at the Ready. Question one, there's a lot of talk about the opioid crisis in the US. Dr. Nathan, what are your thoughts on the cause of this and how to stop it? Again,
Yeah.
we're not asking for your prescription to fix it. We don't expect you to be the one by yourself. We talked about collaboration today. It takes a village. It's not just one person that can do anything. It takes a group of people, a village to make things happen. What would you say about this?
Yeah. There is no easy answer because this has been going on since the 90s, probably late 90s, early 2000s. So we're talking close to maybe 2 decades. A little history on it and my personal belief that could have led to the situation we are in. CMS, the Centers for Medicare and Medicaid Services of the United States government, in 1992, they implemented on the HCAP. I cannot remember the acronym. It's HCAHPS. We say HCAPS. It is
CAPS, HCAPS.
HCAHPS.
HPS.
Yeah. Yeah, it's kind of weird looking, but we
And
say
the
H.
S, would it be a small s like plural, or is it a large S?
Small s.
Small s. Okay, just
Yeah.
double checking to make sure I'm thinking about this correctly. So the HCAPS.
Yeah. So that is essentially a patient satisfaction scoring system. And so if an individual is admitted to a hospital, they get a scoring system from if they are billed to, if the individual is on Medicare, so retirement age, they've got Medicare, they go to the hospital, they're discharged. On discharge, in the mail or email now, they would receive a scoring survey. That survey is then utilized quite heavily to calculate hospital reimbursement. So 30% of the scoring comes from the HCAP survey. So that being said, in the 90s, the federal government added was your pain adequately managed, I believe is what it was termed. And so
That
if an
sounds
individual,
familiar to me. That sounds like that type of terminology that fits what I know
yeah,
about the nomenclature and terminology used.
yeah. And so essentially what was determined was that if you were not 100% pain free in the hospital, you would lose points, thus losing revenue or reimbursement.
Yeah.
So that happened in the 90s. Also, what happened was the development of Oxycontin. It was a long acting opioid that was hailed as a cure all, non addictive, and we found out it was not.
It was not, meaning that it actually is addictive.
Yes, highly
Yeah,
addictive.
highly addictive.
Yes. And so there were things that were going on between the drug company and the federal government that were kind of not ideal or not great for the American people or the general public. It was to essentially line pockets for the individuals in the government and the drug company. So essentially, that's kind of where it started. Then we move into like the mid, like 2010. Then we get a whole nother second opioid crisis, and that is where heroin became abused. And that was mainly due to cost of prescription opioids. So people got addicted to prescription opioids. The government said, hey, you can't have them. So then they turned to heroin. And then heroin became expensive. And what we're in now since 2013 is basically the fentanyl epidemic. It's where we have synthetic opioids, super cheap to produce, And essentially what they do is cut other drugs or lace, well, let's see, they add fentanyl in small quantities to other agents to give them the same
And that's what it would
heightened
mean to
response.
lace. They lace some other drug, existing drug with fentanyl. And go ahead.
Yeah, and essentially just increase the activity of the compound you're taking. So you get a cheaper high or a cheaper action of drug. So that's where we are. It's kind of like it's a waterfall kind of effect. Like
That's
they
good.
started it, they put in legislation to stop it, but it created another issue, and then they fixed that one, and it created another issue. So
In a way, you could say it's a waterfall effect or sort of a snowballing effect in a way.
yeah, yeah,
That it started a long time ago, around 30 years ago. Was that, as I understood, 40 years ago? 30 years
90s,
ago. 90, so
30,
about 30 years
yeah,
ago,
about
roughly
30 years
30.
ago.
Okay. And then, it just continued with policy decisions, arguably bad policy decisions in some cases, or at least not forward thinking policy decisions to
Yeah,
curb or quell a problem that we had, but actually created more problems or new avenues for something like fentanyl,
yeah.
as is our crisis now. Sure, there's still an opioid crisis. Fentanyl, is that part of the opioid crisis? Would you still consider it? That's an opioid,
I
synthetic
would.
opioid.
It's grouped under the synthetic opioid crisis.
Okay. That was
So
my question is it a true opioid or synthetic opioid or
yeah,
opioid-like substance?
yeah. So it's a synthetic. It still targets the mu receptor, but it is an opioid. It acts as an opioid.
It acts as an opioid.
Yeah. And so along the, and I do not mean to sound like it was solely drug companies and um the federal government that contributed. Physicians in that time period were also contributing. Um, with physicians, they don't get as much pharmacology, so it's hard for them to gauge the true.
Say this is a key. Pay attention to this part because this is the truth when it comes to running a hospital and dealing with different departments. Go ahead and continue. I
Yeah,
just wanted to highlight, like, listen to what he's saying here. This is
yeah,
something I think is very important.
yeah. So, for example, when you go to med school, I believe you get 2 semesters, so 1 year of pharmacology training.
Mhm.
Whereas I've had 6 years of pharmacology training to be a pharmacist. Um, and physicians, I mean, not necessarily that they were doing it maliciously, but it was probably due to a lack of education or that they,
It's like we
uh,
talked about earlier, the gray areas in
yeah,
prescribing. They would not be as aware of all the gray areas as someone
yeah,
who studied for 6 years and actually spent a lot of time prescribing, developing drugs for, a majority of people, or for
yeah,
a larger sample size, we could say, of people.
yeah. And I mean, it was new. It was a new agent. It was new data, but there were also components of their program for prescribing. So if the drug companies set up programs where if a physician prescribed X amount of drug, they would get a free vacation or they would get food for the office or some type of kickback. And so it got out of control. And so it was multifaceted in what led to the problem. It's not easy to say one group of people or one person caused it. It was a whole system wide failure.
Sure. And that system went through some very, very big changes as far as pharmaceutical reps and the trips they could offer and the perks and benefits they could give to doctors who they had relationships with. Went through a major change somewhere around 2006, 2007 in the US. I would say between 2006 and 2008, in that time frame would be pretty accurate for new policies that were passed that completely changed. There was a job once, pharmaceutical rep, still exists, but it used to be a big job. It used to be a lot of people who were acting pharmaceutical reps around that time. And then again, somewhere between 2006 and 2008, policies changed, and that saw a huge reduction in the workforce of pharmaceutical reps and a lot more rules and regulations regarding what they can and cannot do when establishing relationships with doctors, hospitals, businesses, and so on.
And I thank you for bringing that up because that's actually a good point. Part of that program now, the drug rep role while it still exists in a altered capacity. So now what they have is medical liaisons, and they are pharmacists. And so they send a pharmacist out to physicians' offices to and doctors' offices and clinics to discuss these agents on a academic professional level. So there's more education. With drug reps previously, they were basically handed a pamphlet that was printed by the drug company and regurgitated it without truly understanding what they were saying.
Good. The reason I know the time frame of this is when I was finishing undergrad, the year before I finished, I interned with a couple of drug reps that, you know, my mother and my grandmother worked in the same little doctor's office in a small town. And we knew a lot of these drug reps. And a couple of them I knew very well. And they said, "Hey, Jacob, you should think about being a pharmaceutical rep." And I was seriously considering it. And I really thought when I finished university, that's what I would do as my first job, be a pharmaceutical rep. And it was at that time, again, I graduated in 2006, 2006, 7, 8, somewhere in there, that entire industry changed due to new rules and regulations. But I knew that a lot of people who were working as pharmaceutical reps they had a business background, right? They had a sales background more so than a biology background. And at that time, I did have a biology background. So the conversations I had with a lot of these reps, even at my lower level of education with, biology, chemistry, pharmacology, so on, I had a better understanding than most of them did about the drug interaction and what was going on. So that resonates very well with me and my understanding of how things used to be. And now, if I have these terms correct, we have pharmaceutical reps as they were in the past, pharmaceutical representative, and then a pharmaceutical liaison would be what they would call now, or medical liaison.
Medical
You said
liaison.
medical. That's what I thought. I wanted to double check. So a medical liaison is the new, more or less equivalent, but with more knowledge title that they would
Yeah.
have. Okay.
Yeah. And and then kind of wrap that question up. There is a show, I think it is on Netflix. It's either a show or a movie, but it's called Dope Sick. It's got Michael Keaton in it, and it does a fantastic job of going through how it impacted the initial opioid crisis in the 90s, how it started, the legislation, kind of shows you the corruptness that was involved from all sides and how it impacted some small, very rural, small town in West Virginia.
What was the name of it again?
Dope Sick.
Dope Sick.
One word. Yep.
Oh, one word. Okay.
Yep.
Dope Sick.
And it's got Michael Keaton in it. He does a really good job. He's a small town physician, and they talk to him, and he starts prescribing it and kind of walks you through his story and the story of the drug company and the federal government, how they're all in flux together.
Sure. And if you're like me and you're thinking, Michael Keaton, what does he look like? What else has he been in? Batman. He was
Yeah.
the Batman, like not the original Batman per se, but one of the most popular or famous of the Batman movies with the Joker in it.
Yep.
With now why in the world am I drawing a blank? Who played the Joker? You can see his
Was that
face.
Jim Carrey?
No, not with Michael Keaton. The Joker was very, very famous, amazing actor, Jack Nicholson.
Oh, yeah.
I was thinking Jack Nicholas, the golfer. I'm like, that's not the name. Jack Nicholson.
Yeah.
Yeah, the original, probably the best in my opinion too. Joker.
Yeah.
So Dope Sick.
Yeah.
Michael Keaton, Batman.
Yep.
Stars in
It
this
does a
one.
great job at summing that question up. Like if you watch it and spend some time, it is longer. I'm pretty sure it's like a series, and I think there's 7 episodes. So I mean, it's like a multi-day thing, but it does a good job at answering that question and kind of it hit the nail on the head for me as far as my thoughts, what I was taught, what I've seen. So it did a really good job.
Sounds good. So Dope Sick once again. All right, we have 2 more questions, Dr. Nathan. Let's go ahead and lean into question 2. Is natural medicine always better than chemical medicine? And what are some benefits of both? Now, again, you can keep this a little shorter if you want. I know we're starting to run long, but I appreciate, and I'm sure that anyone watching this is going to appreciate the just level of conversation we've had and all the interesting information that you're sharing with us. And again, I really appreciate it. I'll thank you again at the end, but thank you for taking this time. It's much
Yeah, absolutely. This is especially in my field with oncology, there is a large push for herbals, which would be natural medicine, herbals, vitamins, supplements, things that may be better or alternative to our chemical or synthetic materials. And all I can say, well, not all I can say, but what I will say is it's not always better to be natural. Uh, Especially because, and here's why. There are if I would say very few clinically designed trials to look at natural supplements when compared to an actual medicine that's been made. They're not going to do any head to head because drug companies are not going to make money off that. They're not going to do a head to head trial looking at, say, vitamin C versus some sort of antiviral. What's the benefit? Like, there's not going to be any benefit monetarily to them doing that. So there's no data, and there are some limited trials and on like a handful of agents, and we do make recommendations based off of those. For example, one of those is ginger, for example. In the oncology world, ginger can be a very useful target. It is very good at preventing nausea. We have dosing recommendations. For example, like 2 grams max daily can drastically reduce nausea in some individuals. So, yeah, on the flip side of that, and this is the negative, is we have what's called the 5 Gs, and it's 5 natural substances. So ginger, garlic, ginseng, glucosamine, and ginkgo biloba. All of those have increased hemorrhage risk. So
and hemorrhaging, what is to hemorrhage?
So hemorrhage would be excessive or uncontrolled bleeding.
Uncontrolled bleeding. Okay, so there's bleeding risk with the 5 Gs.
Yeah. So not garlic, but ginger, while it fixes and helps with nausea, may increase bleed risk. So you have to balance them. So it's not necessarily that, it comes out of the earth, it's safe.
It's safe.
There's moderation, there's dosing. We have to take those into consideration when we're making a clinical judgment. So like if someone has a hematologic malignancy where they're going to have a high chance of bleeding, I would not suggest ginger at all. But if they have a cancer, like a lung cancer, no real risk of bleed, go ahead and give them ginger. It's not going to hurt anything.
You were saying, again, you did mention a sort of dosage of ginger, something like 2 milligrams a day?
I think it's 2 grams.
2 grams.
Per day. And you divide that over like 4 or 5 doses.
4 or 5 doses, not all at one time, divided out throughout the day, somewhere around 2 grams. So not, in general, not more than 2 grams per day. 2 grams or less is safe.
And I will have to say, I am licensed in South Dakota, but anywhere else, I cannot give advice. That is
this is why I highlighted it. You did mention a dosage, and I wanted to make sure anyone watching, I wanted to give you a chance to give your disclaimer there too, because someone may say, I saw this video on the internet of Dr. Nathan saying it's okay to take 2 grams or less. And now I'm hemorrhaging and I want to sue somebody, and Dr. Nathan's the one. So again, this is not meant for medical advice, but just take these numbers with a grain of salt and know that in general, when you talk about natural medicine, it may not always be better. This is what he's saying now, is we always think it's natural. It's fine. My body's natural. I can put natural things in it. It's okay. In moderation and with certain regulation, just like pharmaceuticals.
Yep, exactly.
Okay.
And we have good references. If any individual is wanting to look, my advice is always ask your physician, before starting one. They'll say, ask your pharmacist. But we go to a reference for our oncology purposes. It's from Sloan Kettering Memorial Hospital in New York. They have a really good herbal interaction reference kind of, and we utilize that quite a bit. They have a handful of agents that actually have true data, and so they can actually make a recommendation.
Is that something that's available online that people can find and see? Is that
It is.
public
Yep.
source or public record? Not public
Yeah.
record. What do I want to say? You understand what I'm saying, though.
Yep. It is.
Um,
I can't
what is the
remember.
hospital name again? Just in case
Sloan
anybody's
Kettering.
Sloan Sloan
Yep.
Kettering
Yep.
Kete.
Kate, hang on. Let me
Not
look
sure.
at my phone real quick. Sorry.
No, it's okay. Let's make sure we get the spelling right. I can look it up too. Kettering, Sloan Kettering with an ing.
Yes.
Okay.
And if you type in like herbal, I think it's like herbal drug or herbs and botanicals, maybe. It comes up with a reference and it's got all of them listed. You can select which ones and whatnot.
Okay, let's do that. I'll just type in on the little reference sheet here, Sloan Kettering Herbs and Botanicals.
Yeah.
This will bring up what you need if you want to look these up. But again, always talk to your physician, and then they may refer you to your pharmacist as well. Just like Dr. Nathan said, here's our disclaimer. I'm not going to say it again, but there it is. Good. Hey, thank you. That's, again, another challenging question to answer because it's complex. And again, it leans into giving medical advice that we don't really want to give. But I think your answer was quite good at walking the middle line.
Yeah.
How about number 3, the last one? Would you recommend young people to become pharmacists? Is there a need for more pharmacists in the US and or internationally?
Yeah. So I cannot speak to international need. I do know some statistics about nationally. I know right now it's approximately 3% growth in the field of pharmacy over the next 10 years is what we're shooting at, which is rather slow for what's being enrolled. So a little history. 2006 CVS Pharmacy made a big push to get pharmacists. They were very adamant about I like to call it propaganda about saying, hey, we need all these pharmacists. We're going to have them. And essentially what that created was a cash cow program. So every state school.
That's a good word, cash cow program.
Yeah. So not only did every state already have a pharmacy school or a college of pharmacy, which is great, but it created an environment where private colleges began to open PharmD programs to take in some of that money because everybody was like, oh, I've got to be a pharmacist. It's good salary, good hours for the most part, and it was everybody wanted their kid to be a pharmacist in the middle 2000s. It's like, oh, everybody's got to be a pharmacist. So these colleges, private colleges, they cashed in. Normally the tuition is 2 to 4 times the amount of a state school.
Yes.
The education is questionable at some of them. So what that created was an overabundance of pharmacists, what we have now. And so it's harder probably to get a job without residency. So if you don't do a residency, you can probably expect to work in the retail setting. And if you work in the retail setting, there's a dynamic that's happened where very limited full-time hours. You normally have to work 2 part-time jobs to make full-time hours, etc. If you want to get into a hospital setting, you need at least a 1-year residency, if not 2. And then parts of the United States, for example, like where I came from in Tennessee, we had 6 pharmacy schools in Tennessee. And like my college, my University of Tennessee, they graduated 210, I believe, the year I graduated.
110.
Yeah. And so for comparison's sake, here in South Dakota, and that was just one school, the University of Tennessee, 200, but we still had five other ones. So you're looking at 12, maybe 100 pharmacists. So it's heavily saturated in Tennessee. So, but in South Dakota, their pharmacy school is roughly, I think, 60 individuals.
That's a big difference.
Yeah. And so South Dakota is not as saturated. So it depends on where you want to work and what area, geographic region you want to work, what state even that you want to work, and what field you want to work in. So the growth is there. The growth is going to happen. We do need pharmacists. But when I went through, and even a few years before I went through, things really slowed down because of that massive influx that happened in 2006. So they realize what's happening.
The job market now as a pharmacist.
Yeah. Yeah. It's starting to revert back to where there is a need. And for example, the middle 2010s to about 15, 16, pharmacy growth was at 6%.
6%.
6%, and now it's down to 3%, but it's on the upswing again. So some of it's self-correcting. Some of the private colleges have shut down, things like that. So there's that dynamic and that component of the dynamic. But I would recommend young people, if you're interested and you feel like that's something you're interested in, definitely look into it. Definitely do it. We need good individuals. I will say the field of pharmacy is approximately 2/3 female, 1/3 male. So yeah, primarily female driven, which isn't good or, I mean, good or bad. I just say it just to give you stats.
Right. He's not making a more political statement here or social statement. It's just, that's the way it is.
Yeah. And so there's that component. Let's see. I would say that admittance to a PharmD program is probably going to be easier now than it was, say, when I went. Admittance when I went was more stringent. You had to have certain prereqs, more prereqs, whereas now colleges have reduced prereqs to increase the number of students they're getting to offset that loss of students. So they're taking, again, I don't want to say underqualified, but they're taking students without having a full picture of their academic background.
Okay. That's a good way to say it. Without saying
Does that make sense?
It does. It does.
Okay.
Yeah, they're a little bit, you might say they're hastily admitting people.
Yeah.
A little bit without doing more research into them, having further interviews. They're just saying, okay, you meet some of our basic requirements, maybe not all of them, but we're going to let you come in.
Yeah. And on the flip side of that, they are teaching those prereqs in the first couple of years of pharmacy school. So it's not that you're not going to have them. It's just you don't have them prior to going in.
You don't have to. Yeah. Makes sense.
Yeah. Let's see. But yeah, I would like, kind of like I mentioned before, I would definitely say if you are an individual that isn't dead set on, hey, I want to do this or that field, as far as like, do I want to work hospital? Do I want to work in a lab? Do I want to work in like marketing? And even like for me, for example, I did the dual enrollment and got the master's in healthcare informatics and information management because I'm interested in IT. I like that sort of stuff. I like the data aspect. So they offered it. It was free while I was in pharmacy school. It was a new program. They were like, hey, do you want to try this? And I was like, sure. And so it was extra work, but it was a free master's, and it opens up some doors if I ever want to change and I want to say, well, I'm tired of clinical, but I still like being involved. I can work on the what's called SQL, which is a data program. I can manage on the
SQL
EHR.
for anyone that may not know. When you say, a lot of people, it's not amazing. It makes sense why. When you see SQL, not everyone knows that you say it's SQL. MySQL, MySQL, it's MySQL. Yeah.
Yep.
Database management program.
So there are many avenues that a PharmD degree gets you. It's not necessarily, hey, I've got to look at pills all day or I've got to look at orders all day. Um, it's an endless road in many different directions. So if you like to change jobs or you get bored easy, do the PharmD. It gives you a lot of opportunity.
Yeah, it gives you that versatility to just change your interests every 5 years or so if you need to.
Yep. Yep.
Good. Dr. Nathan, do you have any closing thoughts? Anything maybe that came to mind or anything you want to say to our students in the club who are learning English or to any of the people who are looking at pharmacy school or are pharmacists themselves?
The main thing, especially the main thing is for the students or the people upcoming, just keep your head down. It's going to be hard work at times, but there's a lot of good times too. Um, it's taken me around about, long time to get here. But don't ever give up if that's what you want. Keep working at it. Just know that it's short-lived. The bad parts and the good parts last forever. So
there you go. And
yeah,
you know what? I'm going to piggyback off that and say all the rest of you who aren't thinking about pharmacy school or anything medical, do the same thing with your English. Put your nose down. Yeah. Focus, work on it. It's eventually going to come. You're going to improve and you'll be having conversations just like myself and Dr. Nathan here. Dr. Nathan, again, thank you so much for this time you spent talking to me. I know our students are going to learn a lot from you, as will other people who see this video. We'll post this in the club shortly, and we may also post it on YouTube with your permission. Is that any problem with you?
no, that will be fine.
Fantastic. We'll also make sure within the club and without, we are going to link some of your medical pearls you shared with me, some things he did during residency. Give us just a brief description of what your medical pearls are.
Yeah. So during residency, my second year of residency, we were required to put out or make a clinical pearl each month. And so anyway, they're on different topics and objects within side of oncology. Some of them are overviews of guidelines. Some of them are introductions to drugs, new drugs. So yeah, there's just a variety, a plethora of them. And they're there if you want to look at them. Great. And like always,
Again, it's just
I'm welcome.
Sorry.
Oh, I was going to say I'm welcome to feedback, so you can let Jake know, and he'll pass on the criticism to me, and I will take it.
And he'll take it because that's what we do with criticism. We take it, accept it, maybe learn from it at best, and then move on with it. Good. Yeah, and these pearls, just take them as supplemental material. You do not have to watch them. There is no test or quiz on them or anything like that. Just if you're interested to know a little bit more about pharmacology and about what's going on in the field or what went into Nathan's study, I believe the pearls might answer some of those questions. Also, if you like Nathan's voice, his beautiful voice, you can listen to it a little bit longer in those medical pearls. Again, Dr. Nathan, thank you so much for being with us, and everyone in the club. Thank you for watching this. I really hope you find this valuable, and I hope you learned something. Questions, if you have questions, please do reach out on the various platforms where you see this posted. If there's a comment section linked to this where it's posted, use the comment section, and we will respond to you with answers as best we can. If I need to direct that question to Dr. Nathan, I might do that as well. I don't think he's nodding his head. He seems to not mind.
Yep, that'll be
the
fun.
idea. All right, Dr. Nathan, say your goodbye, and we'll get out of here.
All right. Thank y'all. I appreciate it. Y'all have a good day.
All right, now, everyone, this is a little Southern. Here we go. Well, let's let it fall out a little bit. All right, now, y'all, take care. Good to see you. Thanks for watching, and I'll see you next time in class. Bye-bye.